We are really excited for our first particular panel here. They include Dr. Sue Borson, Dr. Jamie Starks, and Angela Fields. And it's my real pleasure to introduce them now, and I will kind of take you through each of their bios. And I'll start with Dr. Sue Borson, a great colleague and friend of mine. Sue Borson, MD, co-leads the Bold Public Health Center of Excellence on Early Detection of Dementia and is professor of clinical family medicine at the University of Southern California. And she's also a professor emerita of geriatric psychiatry at the University of Washington, where she developed its memory disorders clinic and led the Alzheimer's Disease Research Center's diversity recruitment efforts. I don't know if any of you are familiar with the mini-cog test. If you've gone through primary care and whatnot, Dr. Borson developed the mini-cog. So we're really, really thrilled to have her presenting with us here today. She's deputy editor of the Journal of the American Geriatric Society, and she's also past president of the American Association for Geriatric Society. She's also a distinguished fellow of the American Psychiatric Society as well as the Gerontological Society of America. She also is serving on the newly convened American Academy of Neurology's work group on dementia quality measures. She has many, many collaborations, and she really focuses on research on dementia detection and care delivery. Some of her work that she does that excites me the most is really focused on dementia-friendly health systems. How can we make healthcare systems more dementia-friendly? And she's actually developed a multi-step program to do that. She's also very interested in caregiver resilience and self-efficacy, among many, many, many other topics. So again, having Dr. Borson with us today is a real pleasure, real privilege, and we're thrilled to have her as part of our introductory panel. Our next panelist is Dr. Jamie Starks. Dr. Starks completed medical school and neurology residency here at the University of Minnesota. She then completed a fellowship in behavioral neurology at the University of California, San Francisco. Since completing her training, she's been working at the Minneapolis VA Medical Center, and she's the medical director there of the Behavioral Recovery Outreach Team. She also sees patients in the VA's memory clinic. That's through the Geriatric Research Education and Clinical Care, or GRECC, for those of you that are familiar. She's also assistant professor of neurology here at the University of Minnesota. So again, we're thrilled to have Dr. Starks. Our third panelist, again, we're really thrilled to have Miss Angela Fields share her perspectives. She's a community health worker with Juniper. That's a program of Trellis, and those of you that don't know, Trellis was formerly the Metropolitan Area Agency on Aging. Juniper is a network of organizations that are offering evidence-based programs to help people manage chronic conditions, get fit, and prevent falls. Ms. Fields' focus is really understanding the importance of skill development and workforce capacity building. For example, Ms. Fields facilitates a monthly community health worker peer meeting at the Minnesota CHW Alliance. And she's also just very, very engaged. She has 30 years of experience in the healthcare industry and almost a lifetime of being a caregiver. And so having Ms. Fields share her work with multidisciplinary care teams across a various spectrum of health and community-based organizations, again, is just a very critical perspective. And I think it's really going to augment both Dr. Borson's and Dr. Sparks' panel presentation as well. So again, thank all of you for being here. How we'll do this is each of the panelists will speak roughly 10 to 15 minutes. Then the panelists will spend 10 and 15 minutes really having a conversation amongst yourselves. Then we'll transition to the Q&A session for the audience. So again, thank you panelists, and thank you for being here. Appreciate it.
Good morning, everybody. I guess that's my cue. Can everybody hear me? Yes, and can you see my slides? Okay, great. I wish I could be there in person with all of you today. I'm kind of envious. I can imagine the crowd, and it would be lovely to be there, but I have to settle for this. I'm glad to be part of this panel with Jamie and Angela, and looking forward to your reactions to what we have to say. So I'm going to introduce the problem of dementia-related behaviors from the standpoint of where do they really come from? Why do these things happen? And can we prevent them? Okay. So it's, yeah, okay. This is just a disclosure slide. This is of, you don't need to see this. This is just telling you a little bit about me that's required for most presentations. So the learning objectives that I have for you today are to learn why behavior changes happen and to help you think about using a simple framework for understanding what's going on. I also am hoping to present 3 ways to reduce the risk of behavioral crises. So one thing you should know about me is that my goal in dementia care is crisis prevention. And that's a really big topic, and maybe sometime we'll talk about it in more detail. But here we're talking about how do we reduce the risk of behavioral crises. So it does start with the brain, of course, naturally. And the brain is the most complex known object in the universe. After, I don't know, what, 40 years in the field, I guess I would say, I cannot disagree with this. So on the left, you see a normal brain and then an Alzheimer brain. Many of you have seen pictures like this before, but I show them to you to illustrate the points that in Alzheimer's disease and other dementias, neurons, brain cells, shrink and they have trouble talking to each other. So they get disconnected from each other. That means that the processes of control within the brain itself weaken. Sometimes there's too much activity, sometimes there's too little activity of brain cells because normal activity depends on communication. It's the same as with our society. We have to communicate with each other. Different dementia types affect the brain map differently, and that gives rise to some differences in the behavioral profiles associated with those conditions. So I like to start with the question, what was the person like before? So the person who now has dementia at some stage has been a person long before that. And what kind of a person were they? What were their characteristics? So one of the more helpful ways of thinking about what people are like in terms of personality is a framework called the NEO. Not important, but what is important is these are 5 personality traits and some of their common manifestations that can be used to assess ourselves. I look at this, I think, where do I fit? Well, I can tell where I fit, but I'm not going to tell you. So neurotic, extroverted, open to new experiences, agreeable, conscientious. These are things, these concepts of personality have been really helpful in developing new research on adult development, and they've had some application in the field of understanding behaviors in dementia. But there's more. And how about unhealed life experiences? This is an area of research in dementia behavioral care that has really recently become much more important than it was before. I first understood something about this when I was working at the VA a very, very long time ago. And I saw individuals coming in who had had post-traumatic stress disorder after the Second World War, but had managed to cope and do fine with it. They kept it to themselves. My dad was one of those, kept it to himself. But as dementia evolved later in their life, those memories came flooding in and caused tremendous suffering and behavioral disturbances attached to that. So in addition to adult trauma like that, there's adverse childhood experiences referred to as ACEs. So, and I'll talk a little bit more about that because the study of adverse childhood experiences has now penetrated the dementia field, and because it's such an important underpinning for many, many different kinds of chronic conditions. ACEs contribute to many conditions, both physical and mental, and they influence behavior in dementia. There's even a theory that they may increase vulnerability to developing dementia itself through the biology of chronic stress. So what are they? They include abuse, neglect, and witnessed aggression and violence at home, in the community, or in war. So abuse is mistreatment of any kind, neglect, starvation of any kind, again, including emotional starvation, starvation of relationships. ACEs are often invisible, but they are powerful causes of challenging behavior in dementia. And there's still other causes: acute and chronic pain, physical mobility limitations, inadequate sleep, food, or fluids, acute infection, illness, and injury, and relational factors. This is one that I focus heavily on because this is one that we can often do a lot about. So what are those relationship factors? Communication, for example, speaking respectfully to an individual who has dementia as the adult that they are, or elder speak, baby talk with older adults, recently recognized as one of the important causes of care resistance in long-term care settings. And caregiver fatigue, negative emotions, support needs that have not been met, and insufficient joy. All of these are relationship factors that play into the development of behavioral problems or the sustaining behavioral problems in dementia. Don't get me wrong, there's no guilt to be had here. There's no guilt to spread anywhere. It's simply these are facts and we need to address them head on. I'd like to introduce you to Miriam. She was 83 when I met her. She was a long-term resident of a skilled nursing community, a widow. She was trained as a lawyer in Russia, but she had extensive trauma history. She was a young teenager during World War I, a young adult during the Russian Revolution, and a Holocaust refugee in World War II. Way more than anybody needs to face in a lifetime. After she immigrated to the US, she worked as a refugee advocate, helping immigrants from all over the world. What was the problem that Miriam was having? Well, she seemed racist. She was screaming at the staff. She pushed, she fought. She wouldn't let the nurses care for her, wouldn't allow dressing changes for wounds on her legs that arose from trouble with circulation. Her daughter was at her wit's end. That's how I got involved. She called a social worker who was a friend of hers. The social worker called me. The staff avoided her, giving her only the bare essentials of care because they were afraid of her. And she was, truthfully, the most hated person in the nursing home. So if we're aiming for no crisis care, how do we think about getting there? The first place to start is to assess systematically. I'm going to talk about that, and I know Dr. Starks is also going to address aspects of this. So you need to look for what's obvious, but you also have to find a way to see what isn't obvious in the person and in the situation. You have to accept what you can't change, look for what you can, and then consider whose role is what. What's my role? What's your role? What's someone else's role in mitigating this crisis? So let's look at Miriam's problems one by one. So this is a model I like to use to just organize my own thinking. So starting with cognition up there on the upper left and moving around the circle through emotional and behavioral health, general medical and functional status, care partner capacity and needs, health-related social needs, and the healthcare framework. These are all the kinds of things that we need to consider in assessing a problem. So starting with cognition, let's see what I have on the slide. Actually, I'm not sure I have much. Yeah, she had moderate dementia. Most of her dementia was vascular, but she had some Alzheimer's disease and maybe some Lewy body disease too. What about her emotional and behavioral status? She clearly had post-traumatic stress unmasked by dementia. I could tell you stories, but I don't have time to go into all of it. She had painful leg ulcers, and she had chronic anxiety and depressed mood that long preceded her time in the nursing home, but were never better, in spite of, when I met her, being on 6 different psychotropic medications to try to regulate her behavior and her mood. Her general medical and functional status reflected severe, very generalized vascular disease. She was bedbound, hadn't walked in several years. She was immobilized by multiple mini strokes, and she had intense pain whenever her leg dressings were changed. Her care partner really consisted of her daughter and nursing home staff, and they were all stressed, frustrated, angry, scared, didn't know what to do, and at the end of their rope. What about health-related social needs? Well, after a lifetime of deprivation, she was no longer suffering from poverty. There was no financial strain. Her daughter had done well, and there was no problem paying for her care or anything else she might want, but she was chronically lonely. In terms of the healthcare framework obtaining in her case, in the nursing home where she was, and this was a nursing home that was widely viewed as among the very best in the Seattle area, and still is, nursing assignments and schedules were kept to very, very strictly, yet the management and the nurse leaders were willing to try anything to make this situation get better. So what did we do? Began to think about stress busters. Now, for this slide, I credit the ACEs Aware program, something that all of you should take a look at. This is Adverse Childhood Experiences Aware. This is a remarkably wonderful training program that we could learn from in the dementia field. Training program for clinicians and others. So for the hallmark of ACEs Aware training is learning how to use stress busters. And they're listed here. I won't go through them. You're familiar with all of them, but this is just to keep them all in mind, that these are all ways that we can reduce stress for ourselves and those around us. So what happened here? What did we do? Let's first look at the supportive relationships and mental health care for her. So the main thing that I did with the facility was I got permission to have all of the staff from all the shifts join in a 1 hour meeting to talk about her care. That had never been done before. And what was revealed from that was the hostility that staff felt about her racist comments. I was able to explain to them how those racist comments were so against her own real beliefs, that they came from her current fear based on her dementia, that she was afraid, she didn't understand what was going on, and she lashed out with really insulting comments to staff who were only trying to help her. They took this to heart, and they began to think about how they could behave toward her differently. I took her out into nature. Once a week when I visited, I took her out in her wheelchair to smell the air and look at the flowers in the beautifully landscaped nursing home. I myself practiced mindfulness. Physical activity was beyond her ability because she was so immobilized. Nutrition was good. Quality sleep, now that was a big one. How did we assure quality sleep for her? She had not been sleeping at all. Why not? Because the heart of the problem was she had leg ulcers that were intensely painful, and the staff was very, very good at following the every 4 hour dressing changes that were prescribed by the clinicians caring for her medical condition. So I got permission from that doctor to stop the nighttime dressing changes. Once the dressing changes at night were stopped, her leg ulcers continued to improve as they were doing already, but she was then able to sleep. That was actually probably the most important intervention in turning this problem around for that individual, for Miriam, for her daughter, and for the staff of the nursing home. Very simple, stop the dressings at night. So this has just been a quick introduction to a wide-ranging set of topics around behavioral problems in dementia and how to start to think about management. Hopefully you've learned something a little bit different, and if you want to talk, get in touch. Thank you.
Okay, hopefully everyone can see my screen and hear me. Thank you so much for that wonderful introduction, Dr. Borson. I'm going to be talking a little bit about specifically the role of medications in the management of behavioral and psychiatric symptoms associated with dementia. First, my obligatory disclosure slides. I do not have any disclosures. I will be discussing off-label use of medications briefly in this presentation, simply because there are no FDA-approved medications for this indication. So my goal for this talk is not to make everyone an expert in what to prescribe when, but to have a better understanding of generally when medications are potentially useful for treatments of these types of symptoms, when they are not likely to be useful, understanding some of the complexities and challenges that we face with use of medications for behavioral symptoms associated with dementia, including the risks that are associated. So I want to start off with reviewing a case of a veteran that I saw kind of early in my days doing this work at the Minneapolis VA, who had a lot of really challenging behaviors and went through a lot of different medication trials, and I think helps illustrate some of the challenges associated with this. So this was an 88-year-old retired high school shop teacher who had Alzheimer's disease and was in and out of the hospital over a few months due to behavioral concerns. He had been living at home by himself and was initially admitted after he was found by the police because he was walking around his neighborhood in the middle of the night, knocking on neighbors' doors, informing them that he was constipated. They brought him into the hospital and discovered that there were no medical reasons for the way that he was acting, that these behaviors seemed related to his dementia. He was recommended to either discharged to a nursing home level of care or back home with family providing 24/7 supervision, which is what happened. He went home, lasted a few hours, only got into a fight with a neighbor. Police once again brought him back to the hospital. While he was in the hospital at the Minneapolis VA, he had a lot of behavioral issues that were described as a really labile mood. He would go from tearful to anxious to irritable within moments. He was also very perseverative, focused on different issues related to wanting to go home, feeling like he was being held against his will. And this sometimes escalated to the point of physical aggression towards staff, punching them when they tried to redirect him if he tried to leave the hospital. He was eventually, or after about a week, discharged to an assisted living facility, memory care. And there he only lasted a couple of weeks because, again, he continued having these aggressive behaviors, similar behaviors to what he'd been having in the hospital previously. So at this third admission, this is when me and my team ended up getting involved. He eventually was admitted to my behavioral recovery outreach team, an interdisciplinary team at the Minneapolis VA that specializes in serving veterans with dementia-related behaviors. And he was on getting pretty high doses of an antipsychotic medicine called olanzapine when he got to our team, and also was getting some melatonin for sleep. And when he was on my team, he continued to have a lot of really challenging behaviors. He would be quite mean to staff. He would make racist remarks towards them, hostile remarks, threatening remarks. He was quite paranoid about everybody and everything, convinced he was being held against his will. There was a period of time where he became insistent repeatedly on calling the police and would do so, or attempt to do so, about every 5 minutes. He felt that he needed to leave and would try to do so. And when staff would try to intervene to redirect him, he would become very aggressive and start pushing and hitting and yelling. So he, over the next 4 months, because of the really challenging and behaviors that were putting people, staff members at risk, multiple different medication trials were attempted. And as you can see here, and we'll come back to that later to see how all of that went. So now I'm going to talk a little bit more generally about the role of medications. So there's a lot of different models for thinking about why behaviors occur in dementia. And you saw some great models with that Dr. Borson just presented. Here's another model that I often use, is thinking about factors relating to the patient themselves, the caregiver, whether that's a family caregiver or hospital or nursing home staff, and then the environment. So what I want to highlight here is that of all these many different complex factors that interplay to give rise to these behavioral issues, most of them are not things that we can address with medications. The things that are the factors that we can potentially address with medications really boil down to, my previous slide showed, either psychiatric illness of the type that can respond to medications and disruptions in neurocircuitry, those lost connections between brain cells that Dr. Borson reviewed with everybody. So as the brain in dementia is shrinking and those connections are being lost, there's also alterations in the chemicals that brain cells use to communicate with each other, things like dopamine and serotonin. And so those chemical alterations are things that we can try to modify with medications. Psychiatric comorbidities, depression, PTSD, et cetera. These are also things that we can potentially try to target with treating with medications. There are, aside from people who have psychiatric conditions prior to developing dementia, recognized or unrecognized, as highlighted by Dr. Borson, often they sort of become unmasked when a person develops dementia. But we also think that there's an increased incidence of psychiatric conditions such as depression, anxiety, that in people who have never really been prone to those types of conditions as a result of the brain changes that are occurring. So medications, I think often the perception that people have when asking for a medication to help with a behavioral symptom is that it will be a silver bullet. There's something out there that can just fix this problem. And this is what I think I often hear, particularly from caregivers, nursing staff who are at the end of their rope. They've been doing everything they can to try to manage behaviors, and isn't there something we can give them to just make this stop? And unfortunately, the reality is more like this. So when I was starting out this work, one of my mentors in geriatric psychiatry, she used the analogy of Wild Wild West for describing this area of geriatric psychiatry. When it comes to treatment of behavioral symptoms associated with dementia, it's often really messy, and there's not a whole lot of guidance about what to do. So why is that? Part of it is because, as we've seen, it's very complex, the different factors that are interplaying to give rise to behaviors. And there's also a lot of guidelines about what not to do and less so about what to do. As I mentioned, in my disclosures, there are no FDA-approved medications for treatment of behavioral symptoms associated with dementia. And this is because there's really not a lot of good evidence supporting the use of medications. This is, I think, because this is such a complex problem, and there's so much individual variability in dementia. Every person with dementia is a different person with dementia. And so I think that the studying these medications is really basic. It's hard to do. It's hard to do clinical trials that can account for all this complexity. And so that doesn't mean that medications don't always work, or that their medications can't work or be helpful, but that it's hard for us to develop really good evidence-based guidelines for what to do. So most guidelines and experts recommend non-medication treatments as first-line interventions based on the evidence that we do have, the research we do have. It seems that they're at least as effective as medications, and non-medication treatments, of course, don't have the side effects that we have with behavioral medications, which unfortunately all tend to carry fairly significant risks and adverse side effects, which we'll talk about in a little bit. So why is it that often people do want to jump to a medication? Well, basically these non-pharmacologic interventions, they can be challenging. They're time consuming, they're work to implement. You really need to have a lot of education and training. I think a lot of the methods that are effective for non-pharmacologic interventions or working with people that have dementia are kind of counterintuitive and contrary to traditional nursing training. There's often a perception that they are not effective, and I think that's because the results are often less immediate. With a medication, it feels like you can give it and immediately see the results, and that's to a caregiver who is at the end of their rope, that feels better. But just to highlight again, no FDA-approved medications for this type of symptom, and actually the colleagues in my Minneapolis GRECC just a couple of years ago published a broad review and meta-analysis of medications for Alzheimer's type dementia, including looking at all the data that exists for medications for behavioral symptoms. And their conclusion was that the current data that we have doesn't provide any clear guidance about using any of them for these types of symptoms. And also no clear data that overall the benefits outweigh the harms. And so what we're left with is, like I say, not a lot of guidance. Further, a lot of these medications, in particular antipsychotics, which I think are some of the most commonly used medications for challenging behaviors in dementia, there's the balance between potential benefits and risks is not great. In fact, with antipsychotic medications, there is an FDA black box warning because there overall is a small but real increased mortality rate of death overall in elderly patients who receive these medications. There does seem to be, for some antipsychotics, depending on who you ask or what research studies you look at, a pretty good strength of evidence for their use in these for behaviors, but at best for a very small effect. And that's balanced by, aside from the black box warning risk that I mentioned, a lot of side effects that can occur with these medications. People can become sedated or sleepy, more confused. There's an increased risk of falls, and risk of what's called extrapyramidal side effects, or basically Parkinson's-like symptoms. And lastly, because of the risks associated with this medication class, long-term care standards or nursing home care standards have evolved to require that anybody who's on this type of medication has to undergo a trial taper periodically to make sure that they really need it. And so what I've seen in my work, I work mostly in a hospital setting, is that often people who get started on these types of medications for behaviors in the hospital setting, once they discharge to a nursing home, the nursing home is then obligated to try to take them off of it. And so you can then, if the medication was effective, see the behaviors return. And so they're not an ideal medication for people to be on long-term for a lot of reasons. The other thing that it's really important to be aware of is that sometimes they can actually make behaviors worse. So there's this thing called akathisia, which is one of these extrapyramidal side effects that you can see with antipsychotic medications. And what that refers to is an inner sense of restlessness that's really, really intense. And I think in the dementia population, it's hard to recognize this symptom because they're not able to necessarily communicate what they're experiencing in the way that a cognitively intact person would when they're experiencing akathisia. And I think this can manifest as increased restlessness and agitation, exactly the type of thing that you may be targeting with the medication. With sedating medicines, in particular benzodiazepines, like lorazepam or clonazepam, you can have something called paradoxical agitation, in which instead of becoming calmer, which is the goal of that medication, they actually become more agitated. All of these medications, because they are acting on the brain and in some ways trying to calm the brain, they can actually result in more confusion or delirium. And if a person is becoming too sedated, especially during the daytime, that can interfere with the normal sleep-wake cycle. So with all of these bad things I've just said about antipsychotics or other medications, is there ever a role for them? And I think the answer is yes. And the guiding principle that I try to use in determining whether I will prescribe one of these medications is, what is the goal? The goal should never be to try to make cares easier for staff. They should never be used for staff convenience because of the risks and side effects I just reviewed. But rather, I try to think about whether a person's behavioral symptoms are causing them psychological distress. There's this concept in the palliative care world of total pain, where psychological pain, spiritual pain, is equally deserving of treatment as any other type of like physical pain. And so the analogy I use is, if you think of a cancer patient who is in terrible physical pain, prescribing them strong opioid medications may result in sedation and other undesirable side effects. But if the goal is to treat their physical pain, then it's an acceptable risk. So I use the same analogy with behavioral symptoms. And then of course, if behaviors are posing a safety risk to them or others. And it's also important to recognize the types of symptoms that are more likely to respond to medications. If a person is repeatedly asking questions because they have very impaired memory, that's not something we're going to be able to fix with a medication. But if they have hallucinations, delusions, depression, et cetera, those are things that are more likely to respond. Trial and error is often necessary, again, because of the lack of good guidance that we have. And I think also really, really essential with all of these medications is having really honest conversations with caregivers or decision makers about the risks and benefits, and making sure that everybody is on the same page and aware. So just to wrap up this case, I'm going to go through these different medication trials. So this patient came to us on an antipsychotic, trying to target the intense paranoia that he was having, wasn't working. We had added an antidepressant because he was really tearful. He seemed like he had a history of untreated depression when we went back and interviewed his son a little bit more. And as his paranoia continued unabated, we tried to switch him to a different antipsychotic, risperidone, added a mood stabilizer because he was so labile. things continued to be really challenging. So we tried a dose of lorazepam to see if that might calm things down, and he just became snowed. So we tried a dose of trazodone, which is an antidepressant that has some sedating effects that can sometimes be useful to calm people down. And that actually did not calm him down at all. It seemed to make him more anxious. And so now we had a very anxious exit-seeking patient on our hands who also was really unsteady. Then lastly, we tried switching him to a different antipsychotic, trying haloperidol. It seemed that the as needed doses of that were somewhat helpful. So we tried putting him on scheduled haloperidol. And at some point, at some point, I thought, you know, he's getting more and more restless and more anxious despite adding all of these different medications. Perhaps he's experiencing this akathisia, this restlessness. And so we tried tapering him off of antipsychotics completely. And remarkably, he got better. So I learned that we were really kind of chasing our tails and actually making things worse despite trying to make things better. In his final month with us, he had no paranoia, no exit seeking. He became calm, easier to redirect. And I think a lot of what he had been experiencing was actually something that we had done to him with our medications. So I will leave it there. Thank you so much.
Right. Okay. Good morning, everyone. I'm Angela Fields, and I'm a community health worker. I would first like to say I'm honored and humbled to be here before you today to talk about my caregiving perspectives and to share my strategies and tips that were helpful for me being successful with helping and assisting those that I care for manage their dementia-related behaviors and issues. I would first like to talk a little bit about a community health worker, who we are and what we do. A community health worker is commonly called the CHW. We are trained frontline public health professionals. We have a strong community connection, could be language, culture, life experiences. We bridge gaps to care, health and social services, and the community. We create access to health and community services and resources. We provide culturally appropriate health education, information, and outreach in various settings, including the individual's homes. We work inside of clinics, hospitals, care centers, barbershops, beauty shops, schools, etc. There's also community paramedics and community pharmacists. We advocate for inclusive and equitable healthcare for all. I would first like to say thank you to all the caregivers that are in the audience today. Caregivers are vital members of the care team. Caregivers are the eyes, the ears, and the sometime voice of or for those that they care for. Today, I'm going to talk about CHW strategies for caregiving. I take on that role. I've always say that I was born and reared to be a caregiver. I come from a history of a family with a history of chronic conditions as well as premature death due to chronic disorders. So I've always been since such a young of age in a caregiving role, starting with my parents, on to my grandparents, and now my siblings. That inspired me and was the driver for me to become a professional caregiver. And I stand before you today as a community health worker. I would like to share with you some tips and strategies that I've utilized throughout my career to help me manage situations where I encounter individuals with dementia-related behaviors and issues. I would like to say that the general rule of thumb is when you're caring for someone with dementia or memory loss, to recognize all behaviors as a form of communication. Recognizing major challenges such as behavior and personality changes, agitation and irritability, sleep hygiene issues such as wakefulness and sleep disturbance. Next slide. Next slide. There we go. Wandering, eating too much or eating too little, fearfulness or crying spells. Next slide. Triggers associated. What are driving these behaviors? Assess the situation and the behavior patterns. Identify the causes of these outbursts or these in the moment behavior changes or displays of behaviors. The environment. An individual may be in an unfamiliar surrounding, or that certain beats may be a trigger. Television noises can be a trigger. Even smells can trigger someone. Take into consideration the personal needs of an individual. Are they hungry, thirsty, maybe in pain, or they're bored? Disease progression can be an indication of some symptoms. They may have a history of wakefulness or sleep disruption. Next slide. I'd like to share with you some behavior management tips. Taking on a person-centered approach. Meet the person where they are, be in the moment. Personal preferences of the individual. Utilize that person's strengths to redirect or get that person's attention. Communication. Ask simple, axable questions and use clear statements in a calm voice. Listen with all of your senses, your eyes, your ears, and your heart, most importantly. Have empathy and compassion for that individual. Stress management tools, soothing tools are very helpful to cause, such as quietness or quiet times, crafts, music, dancing, coffee, television shows. When the going gets tough, distract and redirect. I would like to share with you today a story that of a caregiving experience that is near and dear to my heart. I've been in the health and social systems. This will be my 35th year. But today I would like to talk to you about a personal experience, a personal caregiving experience. And I would like to talk about my recent experience for caring for my eldest sister, who is 15 years my senior. For privacy purposes and confidentiality, we will call her Anita. And my sister and I are 15 years apart. So when I was born, she was more or less already set in her trajectory of life. She went on to go to college, and she got married and built her family. And oftentimes she would live out of state. We didn't live in the same state until our mother had gotten older, and she came back to help me. Can you go back to the next slide? Back. Back again. Yep, we'll start right here. And so when she came to help us care for our aging mother, that's when I was able to really get the opportunity to kind of learn my sister. But at that point, I was transitioning myself here to the state of Minnesota with my family. So then again, we were faced with being distanced as sisters. Later on, after the passing of our parents, my sister and her family moved here to Minnesota. At this point, my sister was diagnosed with multiple chronic conditions, and she required, and she had complex care needs, and she required a lot of attention medically. My sister, I would intermittently help, but I was enthralled in my own career, my own family. It wasn't until about 10 years ago when my sister could no longer stay in her home. And she was cycling in and out of long-term care facilities, transitional care facilities, hospital, and such. Until about end of 2018, when she was admitted into the long-term care facility, and her husband had decided that he's also aging and that her care needs were far behind what he could provide. And even with home care and supplemental care and alternative services, the burden of caring for her was just beyond what he could provide. My sister had been diagnosed with early onset dementia. And we assumed that one of us would eventually get it because my grandmother at the age of 48 was diagnosed with early onset dementia. And lo and behold, it was my sister Anita. So at that point, I agreed with the process. We admitted her into a long-term care facility. We took turns to help and visit and help her as she adjusts, because we were told due to the pre-admission counseling visits that this is one of the things that may be troublesome or could stem some behaviors, because she was used to one way of life. And so it oftentimes when an individual is admitted into a care facility, they have some adjustment situations or some adjustments to take place. So we knew some of the things that would be normal, and we were expecting of that. And so we tried to rally in our community and rally as family to take turns and keep her company and keep her engaged in activities. But then on March 17th, the year COVID became prevalent, we were locked out. Actually, we had arrived there to have a celebratory dinner with her, and we were met at the door and said that we could no longer come in due to the COVID restrictions. After that, my sister took her health took a complete nosedive. She was cycling in and out of the hospital. She reverted into herself. Multiple times she would deny treatment. She would deny food and water. She would become combative, and her behaviors just became ramped up. We had the family asked for a care team meeting. And when we met in person with the care team, we asked questions about her behavior. And we were told, this is her behavior plan. This is her behavior track. We asked for how could we help? And so we asked about patient-centered care. And we received the response that they were doing the best that they could, considering the COVID virus. They also had positive COVID residents in their facility. And so the priority was to keep everyone safe. And so we, as a family, had to rally together and figure out what we can do externally to kind of help out. So we started having vigils at her window, because blessingly enough, her window was on the first level walk-up floor. And so we would have family visits via her window. And the staff started letting us know that When we would come, she would be more pleasant. She would be more cooperative to engage with them. She would be less combative, but they had issues during the night after when no one was there to help out. As the year of 2020 transpired, I sustained a spinal injury. So I was out of the loop for coordinating her care. So her visits became less than infrequent. And due to that, my sister's health digressed to the point where we were told that she was experiencing end-stage dementia and hospice care was recommended for her. She was sleeping about 18 hours a day, and I was really concerned about the quick deterioration that could occur to her body. And so I pushed forward with all that I could, and I embraced with my community to organize my sister to be brought home. So that December, my sister was discharged to my home, and we had the most huge welcome home party that you can imagine. Everything was pleasant for the first 3 hours. As the day transpired, I did not think, I was so caught up in emotions and welcoming her home, I did not think that we overwhelmed her. I did not think of any of the professional things that I would do if I was taking care of a patient or a client. I just was welcoming my sister home. By the end of the evening, I said to myself, what the hell have I gotten myself into? Pardon my language, but that is transparent as I could possibly express this. She was in a full-blown psychosis by 10 p.m. that evening. I had no clue how to handle that. I was taken back. I was completely in shock. She did not even recognize me as being her sister. That was a complete reality check for me as a sibling and as a professional. I had questioned everything, including my ability to care for my sister. And I had made that promise to the family. I had made that promise to her providers. I had made that promise to her spouse that I would bring her home with me. And if I was given a hospice diagnosis, that meant that there's no way to go but up. And so I had to put on my professional lens. And so I had to delegate individuals to be her direct care provider. So there I can step back and I can look at this from a professional lens and figure out what to do, because I couldn't send her back and no one else was willing to take her. And so I said, it's me and you in these trenches. And so I thought about that it brought me back to that person-centered approach. Meet that person where they are. Be in the moment. What are her personal preferences? What are her likes and dislikes? How did she communicate prior to this? I had to listen with everything. So what I did, I installed a camera because we wasn't sleeping anyway. So therefore I can be the ears and eyes for her. And I developed management tools that I could implement. And then when the going got tough, I redirected. Next slide. I thought about other considerations, the biological effects of her memory loss, the predisposition. It was already in her genetic makeup. The cards had already been dealt. And so the environment and her lifestyle was a perfect storm. I thought about her other comorbidities. She had hypertension, she had diabetes, she had COPD. My sister's highest weight at one time was 726 pounds. She had other issues. Her body was covered with ulcers. She had rheumatoid arthritis, and the list went on. So I had a lack of understanding of the brain, the disease, and the disorder. And I had the historical perspectives of her lack of trust of providers. And then I had to take in the fact that how could I help her and look at our economic factors. I had to think about our cultural consideration. With our other family members who are also care providers, be okay with my directions. And then I had to look at was her lifestyle prior to her coming to me, her diet, her exercise level, her sleep hygiene. My sisters never slept. She was nocturnal. She was up at night and slept during the day. So I had to figure out, I need help at night. So I had to hire someone to come at night. Next slide, please. Caregivers, burnout prevention and self-care is imperative. Don't forget to take care of yourself. You're not alone. Build a team and be willing to delegate. Family, friends, church members, colleagues, an hour, 15 minutes, somewhere where you can just step back. I had to take a step back from being a care provider, get that moment of clarity, that quietness, and think about what strategies or what can I do next? Because it was not just for the care of my sister, it was for the care of myself, because I'm her delegated responsible person. So I had to take care of myself. Also, community-based organizations, CBOs, connect with CBOs, connect with them, reach out to them, see what is tailored services for your individual's needs. My sister is a senior. What kind of day programs do they have? What kind of peer programs do they have? What kind of outings do they have? Thinking, outside of the box. My sister loved to bake. So we got into a virtual baking class. And then I started putting on baking shows for her to get her to sleep, because she would not sleep. She did not like my 600-pound life. But my 600-pound life started playing about 4:30 in the evening all the way to 6 a.m. in the morning, because she did not like it so much that she would just drown it out and reject it, and would cause her to bundle up and go to sleep. That I needed that sleep, because I was pouring from an empty cup. And when you're enlisting community support, caring and sharing and considerating, you got to take in consideration the individual's cultural norms. What are their biases? What are their stigmas? And you also have to think about the economical factors. We could not afford a respite care service. That was not in our budget. So I had to barter, or I had to enlist other individuals in my family. I have 6 children. And so I had to enlist each one of them. Everyone had a job and a responsibility. I had other siblings near and far, and each one of them had a responsibility. So I can keep some normalcy in my life, because at the time I was working remotely. So when I'm at work, I have someone calling the doctors. I have someone doing the pharmacy delivery. I have someone doing that. And I just operated as the care coordinator. Find out where your niche is and what you're good at. And that's the services that's how you can provide the successful services for your individuals. And I will close with, I know that I'm coming to the ends of my time, is all behavior is a sign of communication. Thank you.
Uh-oh. Can't hear you. Cannot hear. Okay.
Well, I don't know if they heard me.
Yeah.
Okay.
Yep.
What's that?
We can hear you now.
Yep. We can hear now.
Okay. Okay, sorry about that. I was just saying that I have the in-person question cards, and Katie in the back has the Zoom question cards, and so we will ask questions interspersed among your discussion. So If you want to just start your discussion, and we'll start asking questions as time allows. And we have probably about 20 minutes. I actually don't have the time up right on my computer here, but okay, go ahead.
Well, are we supposed to just talk now?
Yeah, if you want to, or I can start with the question if that would be helpful.
Well, actually, I wanted to highlight one thing,
Sure,
and
yeah.
that is about the issue of self-care for caregivers. I think Angela really talked about it. I touched on it a bit, and Jamie came right up to the edge of it. But I think that from the time I got into the dementia field a very, very long time ago, caregivers have always said, it's not about me, it's about him, it's about her, it's about somebody else. And what we've learned over the last umpteen years is that it's always about all of us. And so this issue of caregiver stress management and really learning how to create a harmonious interpersonal environment, which is what happens when you do good stress management. You stop projecting your stress onto another person. That is one of the most toxic things that happens in dementia care, is that projection of stress. And although I may not have expressed it that well in my case presentation, that was what was going on with Miriam and the staff of the nursing home. Everybody was projecting stress onto everybody else. And the effective intervention, among other things, was to stop that contagion. So I just want to highlight that all of us really are in agreement that caregiver stress management for professional caregivers, for home caregivers, for unpaid so-called informal caregivers, all of this is really core to the issue, or to managing behavior well.
I completely agree with that. One of the things that we know also is that when people lose their abilities to communicate verbally as well as they used to, that they're more reliant on the nonverbal forms of communication. And so there's this notion of emotional contagion where individuals with dementia often have a heightened emotional contagion in which they are more likely to pick up on people's emotions and nonverbal cues more than you or I might. And so I totally agree. It's really important, not just for your own well-being, but for the person living with dementia to be able to manage your stress.
Excellent. I could add to, especially with individuals with Alzheimer's, they don't lose the ability to pick up on nonverbal communication. So that stress and those kind of the tension that you hold in your body and tone of voice can definitely contribute to someone's reacting to that because they know. I will add in a question here for you guys. Do you think that this will be a growing problem, meaning more behaviors, more stress, as we're all suffering from the PTSD of coming out of the pandemic? Is this something you think we'll see more in the future, and people will kind of hold the time that we're living through now on as we age and develop dementia ourselves?
Well, first I'll comment that we're certainly seeing the effects of it on the patients currently living with dementia, and the isolation, the different support systems being closed off, or activity centers, things of that nature. Some of the really essential pieces of prevention of behavioral issues we've lost in the pandemic. And I think we've all been seeing that. As for the future of how this pandemic will affect us all in the future, I'm sure there won't be lasting effects. I don't know if the other panelists have thoughts on that.
I would hope that we could learn from this about and kind of bring ourselves together in the middle of all the division and the stress and the change in lifestyles and the ongoing. I mean, one of my mentees just canceled a meeting because her husband, and their 3 children all have COVID. And it's just, it goes on and on and on. But I think that people who are in caregiving roles maybe have more of a leadership requirement than we know. and that is to be ambassadors for kindness. And Angela really spoke about that and feels that. I think we all feel that. I think that we have an obligation to try to call it spread kindness whenever we can, both professionally and in our personal lives. And that's the antidote, isn't it? What else can we do?
And I would just like to add that I don't have all the exact numbers. I don't have my notes. I apologize for that. But my new assignment as a community health worker through Juniper, I am cited at the Presbyterian Homes Health Systems. And so through that, they're integrating CHW and CHW work within that health system to engage with the 55 plus community and do assessments, including the social determinant of health screening. And that is to look at the patient's or the resident's social needs as is related to, housing, food, safety, mental health, and how these areas, transportation, those social economical components, and how these can have a significant impact on the quality of care that these individuals receive, as well as how these individuals are aging well. And so we do have questions on that screening pertaining to the COVID restrictions and isolation and such. And so we have also with Juniper, we have classes that was created during the pandemic, Social Connect. And so seniors we know aren't always virtual, so they can, if they have access to a phone, they can talk with their peers. And so we're seeing improvements, and we're collecting data on this this pilot that we're doing so that we can understand their needs more thoroughly in our health system that we're working.
Excellent. Katie, did you have a Zoom question for us?
Yeah, we've got a few Zoom questions. Angela, would you mind telling us how your sister's doing now, or kind of where you're at?
Absolutely. After 10 and a half, 11 months of being with me, we were able to establish a network of care and a team for her. And now she has transitioned back home with her husband with all of her services in place. She attended her first church service about 2 weeks ago, and she has a power wheelchair, and she was alert, and she's getting the care that she needs. And so I feel very thankful, honored, and emotional to see her transitioning from a hospice diagnosis to actually back in her community thriving.
Yeah, that's amazing. I mean, that's a wonderful, I can't believe you didn't share that within your story. That's huge. All right. All right, our next question. This is for Dr. Starks. Do you have any experience with using vitamins or homeopathic treatments or non-sedative ADHD meds?
I have not had experience using those for behavioral symptoms. There were some studies looking at high-dose vitamin E for Alzheimer's disease, not specifically for behavioral symptoms. I wonder, actually, Dr. Borson, you've been in this field much, much longer, if you have any thoughts about any of those medications. I have not personally had experience with them.
This is a tricky question because there's the experience of people who do use them, and then there's evidence of efficacy. And so for most interventions that you're referring to, there isn't an evidence base. There's an experience base. And so I look at this, and so for clinicians are really asked and tasked with basing their care decisions, their treatment decisions on data and evidence. we can't do that all the time because there isn't evidence that guides us well enough. So I would put homeopathic remedies, Bach flower remedies, for example, and traditional homeopathic remedies and other kinds of interventions that would include aromatherapies and massage therapies and acupuncture. I mean, there's a wide range. Acupuncture has an evidence base to a degree for behavioral treatment of dementia. It's a small evidence base. But for those things that are not part of traditional so-called scientific or Western medicine, we just don't have evidence. And so we choose, my approach to this is I want to match what people feel would help them. If it feels safe to me, unless it's dangerous, I say, yes, try it. And then let's track it. Let's see how this goes. Let's see if it seems to help. So I would put in that category, and I hope I don't offend anybody with this, spiritual connections. So in medicine, we have lost our ability to use spiritual communication as a way of helping people to a very large degree, because again, it isn't evidence-based, it's not scientific practice. And yet we know from experience that people who have strong faith need spiritual communication in order to organize themselves. And that is true. We can often make connections with people if we can enter their world. We may not have exactly their faith, but we can enter the world of their spiritual life imaginatively. And that imagination and the bonding that it allows us to do is therapeutic in itself. So that was a long and very, different answer than just to the question that was asked, but I hope that it sheds a kind of different light on this and creates a different context for thinking together about it.
I really like the framework of evidence-based versus experience-based in this. As I said in my talk, it's hard to get good evidence for this specific problem because of the complexity. So,
All right, Katie, do you have another one?
Yes, a few more here. Sue, this question is probably great for you. Is there a simple assessment tool to know what's normal aging versus what's potentially dementia or cognitive impairment?
Yeah, I mean, there is a simple tool, and you're asking the person who created the mini-cog to do that job. And so my answer to that is there's a simple tool that does a pretty good job of picking up what I call clinically significant cognitive impairment. And that includes dementia, various dementias. It includes lesser degrees of cognitive impairment. But from the standpoint of everybody who thinks about it this way really needs to be aware that there is no screening test that is definitive for anything. What a screening test allows you to do is establish what we would call a probability that there's a clinically important problem here. It doesn't tell you what it is. It doesn't even prove that it's true. And so normal aging, whatever normal cognitive aging is, it's pretty subtle. And it's the kind of stuff that happens when you go from one room to the next and you're busy doing something else and you're not paying attention and you forget what you went for. That is the classic kind of normal aging kind of thing. Or you forget a word, you forget a name. And normal aging also involves I think of it as kind of compartmentalizing more. If you're in, and this happens to me a lot, by the way. So I work on my computer a lot. I use a lot of mental effort in my work. My work is mental. And I find that when I'm hours on my computer, ensconced in some major kind of mental activity, intellectual activity, and going from meeting to meeting and talking to people about the work, I find that I get I need to reorient myself when I get off the computer and go to make dinner. You know, it's like, oh, what were we going to have? I can't remember. What did we talk about? You know, that's normal aging. At least I pray that it is. So Minicog works for this. There are many other tools that do. The Minicog is the best validated of the short screens and has the thing that really was so nice to learn about the Minicog a lot from other people's work, and some of it in Minnesota, by the way, is that it's associated with some kinds of important health outcomes. You know, if people don't do well on the Minicog, they are at higher risk for postoperative complications if they go through surgery. Even if they don't have a so-called diagnosed dementia because nobody bothered to make a diagnosis, but the Minicog failure itself is a marker that this person is at higher risk if they go through surgery, and they need neuroprotective strategies if they have to have an operation. There's a long list of these kinds of effects. I hope I answered your question well enough.
All right, I have another one for you, although I'm very intrigued by what you just said and have follow-up questions, but I will stick with the questions here. These are really good. So how do you identify triggers for challenges such as wandering, agitation, etc.?
You're asking a question about how to know, is that right? How to know that an
Basically,
individual is likely to have a problem.
Right.
Well, I would turn
Or
to
what might
Angela.
what might trigger it?
So,
right before it
I mean,
happens.
I think we would all agree, and I'm going to then turn it over to Angela and Jamie, but I think the way we figure this out is through our perceptive, you know, we filter through our own perception. And Angela's a natural caregiver. There are in our population, there are people who are natural caregivers who have perceptive abilities that go beyond the average person. And it's also possible to learn to become much more perceptive by working with people who have dementia and connecting with them at the heart level, as Angela talks about. You make a heart connection and suddenly you begin to understand something more about the person. So there's a question about the individual, knowing what an individual's triggers are. And then perhaps a part of your question is, what have we learned about environments that can what aspects of an environment can function as a trigger? And for that, I'm going to turn the rest of the response over to Angela and Jamie.
I'm just going to quickly mention that, you know, if you are someone who is new to this or it doesn't come as naturally to you, I think having some kind of framework where you can systematically think through the different potential factors. There's a lot of different models out there, the DICE model, or even what I had in my slides, just trying to break it down into patient, caregiver, environment factors is a place to start. And I'm most interested to hear what Angela has to say.
Well, for myself, I wear a dual hat as a care provider. So I'm a personal care provider for family members. I'm the go-to person and a turn to. And I'm a professional care provider for those that I care for throughout my network. And so I find it almost, it's a challenge on both perspectives. On the professional lens, I can look at the individuals. I have privy to their charts. So I'm getting some historical background from clinicians, and I'm looking through and I'm doing my research. So I'm prepared. I'm ready to go, and I have that professional lens on. And so I pick out certain things that I may see in their chart, or when I interact with them for the first time, a door opener for me or potential for me. But I have that hindsight because I've been doing it so long that I try to get that sense. So I'm better prepared. And then that first initial encounter with the individual, I get a little bit more prepared, but then I also like to sink back into an individual's environment and just watch them naturally flow into what I call their community. It can be their homes, it could be a long-term care facility and such. Oftentimes on my job now at my site, they often find me in a little corner, just watching and observing and understanding the individual. So when I have that interaction with them, I can say something that will build a rapport. I can figure out that connection to get in, or I can intervene in a way that I'm a non-clinician, so I'm more trusted because they view me as a community member. So I have a sort of an edge in that fact. And I use the individual strengths. If I see that they like coffee, I'll start a conversation about coffee. So for 20 minutes, we talk about coffee. I have a resident that she likes the polka. So can you imagine a little African-American woman dancing the polka? But you better believe I'm asking her, I'm building a library. So when I go into her room, if she's combated or she's in one of those, I can see it. She has cycles. She has built up cycles. So if I can catch her before we get to a full meltdown, we're dancing the polka. On a personal perspective, when I'm caring for my family members, of course I know what's going on. I have an intimate connection with them, and so I also use their strengths, and I also use their likes and dislikes to help soothe them with their likes or redirect behaviors. Take into consideration, their environment, the environmental influences, or what's in the environment. Is there loud noises? For my sister, she didn't like animals. I had a dog, and he's so loving and kind. He's a part of the family, and she's seen him on videos. I didn't think that she would have a visceral physical response to him in the environment. And he was a natural helper. He wanted to help her, but he agitated her and he produced certain behaviors. So we had to retrain him in a way or keep them separate when she's full blown until she was able to accept him into the environment. She had difficulty doing tasks, and that frustrated her. She was an artist. She liked to draw. She used to win calligraphy contests. So I would go out and get big pens help her write. And so when she was able to make that cognitive physical connection and start being able to use her hand, that was her way of expressing herself, let it out. I remember one time she was yelling and screaming, and I was so frustrated. I just started screaming too. And she got the blankest face. It was like one of those mommy meltdown moments, like, what do you want? And she just froze. And it was like, I started crying because I just had a meltdown, and she started crying. I asked her was she okay? She said, I just want you to be okay. So she did have that human breakthrough, even though she was going through, she had concern, and because she had love for me, and her inability to communicate. The more she became verbal, the less some of those behaviors transpired. So it's just meeting that person where they are.
Excellent. All right, we have 5 minutes left. I have 4 questions, and I know Katie has some back there. So we're going to have to either answer some of these by email later, or get through. Probably do our answering faster here. But Katie, it's yours.
Yeah, and thank you to the panelists for answering some of them via the chat online here. We appreciate that. The next question is, do you have any tips for working with someone who doesn't accept or understand their dementia diagnosis? Maybe they're in denial or have some behaviors related to that.
So I think part of it is what Angela was just saying, is meeting them where they're at. Sometimes people living with dementia are, as a result of their disease, incapable of understanding that they have dementia, no matter how many times you try to explain it, convince them, rationalize. Often doing that is upsetting to them without benefit. So I think I'm interested what others have to say, but I think if someone is incapable of understanding that they have Alzheimer's, you don't need to try to convince them of it, and try to support them and their needs without kind of reminding them or convincing them of their diagnosis. Sorry, my child is screaming. I'll let someone else take it.
I agree. Meeting that person where they are, embracing that person's strengths, highlighting that person's strengths, and working with that individual at their current state of ability, whether it's physically, emotionally, or cognitively, starting right with that person-centered approach was helpful for me.
Excellent.
Along with that, maybe, do you have any phrases that you've learned that are helpful when, like, kind of to say when somebody has agitation or behavioral episode? Like kind of a first right off the bat approach, and maybe that just goes along the lines of what you've been talking about.
Yeah, I would say it would. I would make it more personable to that person. And so, or to your other care providers on your team, because you do have to encourage them as well. It could be very taxing on the team in general, caring for individuals, especially in a home setting, because you don't have clinicians around all the time. And so that pep talk to your teammates and colleagues is helpful. Also to the individual, my sister and I, we have trigger words. So she would call out a lot for our grandmother. And when she would go, especially when she would start sundowning, and she started sundowning earlier than what I had expected. It was started around 2 p.m. And so I learned the patterns. And so I would produce different smells. She was a baker. So I would get different candles to smell like strawberries, or like one of her strawberry cream cakes. That was a specialty, or vanilla. And I would say mama dear, because that's what we called our grandmother. And so that would bring, you could just see her calm down, and she would start even communicating to mama dear. And I look identical to my grandmother almost. And so she would always code switch back and forth. And I use that to my advantage. So one day I was Annie, her little sister, and the next day or the next minute I could be mama dear. But I played that role and I played that part to conduce that behavior that I needed to produce so I could successfully take care of her. So getting to know that person, getting to know their niches and their key words or phrases, what can help you in those situations. And it's just, in the moment sometimes.
All right, with that, it is 10 o'clock, so our first presentation is officially over. Thank you so much for being here with us today and all your information. It was absolutely wonderful. So thank you, thank you, thank you. These other questions we will definitely get to you guys, and I'm going to turn it over to Joe.
Thank you.
Thanks.
Thanks so much, Robin. Thank you for that incredible panel. What a great way to kick off the conference, huh? Such great information and resources. Thank you. Quick reminders here. We'll come back from our break at around 10:15 for our next presentation. I just want to point out your folders here. I think all of you are familiar with them at this point. We have a lot of great information in here. Included are 2 colored pages. These are for what we call our registry. You see the blue one is for families. The yellow one are for professionals. If you're willing to help us out and fill out these forms, this allows us to contact you to tell you more about different kinds of opportunities we'll have available at the University of Minnesota as it relates to research opportunities. I know many of you here have participated in some of our research projects in the past, and again, we would like to continue to reach out to you in that regard. So please consider filling these out. If you're in person, if you're online, we send you the links as well. Otherwise, we'll see everyone here at 10:15 for our next presentation. Thank you, everybody.